And without further ado, acute myeloid leukemia and myelodysplasia-related changes, AML-MRC, an evolving diagnostic and therapeutic paradigm, with Joshua F. Zeidner, MD. Dr. Zeidner, welcome. Glad to have you here today.
It's a pleasure. Thank you for having me, Tim.
Absolutely. So, Dr. Zeidner, an associate professor of medicine at the University of North Carolina School of Medicine, Lineberger Comprehensive Cancer Center, and the inaugural director of clinical cancer research, commercial integration at Lineberger Comprehensive Cancer Center, and serves as section chief of leukemia research and associate chief of research within the Division of Hematology at the University of North Carolina. Research focusing on drug development, early phase clinical trials, and innovative therapeutic strategies in acute myeloid leukemia and myelodysplastic syndromes, with a particular interest in immunotherapy and apoptic pathways. And you've designed and developed multiple phase 1-2 studies in AML and serves as the principal investigator on a multitude of cutting-edge studies on AML and MDS. That's a pretty full resume there.
I'm surprised you did that all in one breath.
And what might we know about you outside of your professional bio there?
Yeah, some of you, I think when I did this presentation a few years ago, I do a charity event with Leukemia and Lymphoma Society each year, where we have we raise money for Leukemia and Lymphoma Society doing karaoke.
Oh, okay.
And I have become a professional karaoke charity performer through this event, and I'm being facetious about the professional part. But in my prior years in high school, I was in a rap group, and so really enjoyed performing.
Oh, yeah. That's great. Good for you. All right. Well, the question I mentioned, poll everywhere. Acute myeloid leukemia is a type of cancer of the blood and bone marrow with excess immature white blood cells. That's true, false. That's just the screenshot. I'll pop up the real one, and you can go ahead and answer that now. And then I've got our obligatory disclosures. This activity has been planned and implemented under the sole supervision of the course director, William A. Wood, MD, MPH, in association with the UNC Office of Continuing Professional Development, CPD. The course director and CPD staff have no relevant financial relationships with ineligible companies as defined by the ACCME. The University of North Carolina Chapel Hill is accredited with distinction as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. A potential conflict of interest occurs when an individual has an opportunity to affect educational content about healthcare products or services of a commercial interest with which she has a financial relationship. The speakers and planners of this learning activity have not disclosed any relevant financial relationships with any commercial interests as pertaining to this activity. The presenter has no relevant financial relationships with ineligible companies as defined by the ACCME. Can I breathe now? Okay. All right.
We're only halfway through.
There we go. Yeah. Well, we're done with that. So seem to be running pretty strongly on the A. How are they doing there?
Yeah. No, that's great. Hopefully that we keep it at 100%. It looks like that's for the true value there.
All righty. Well, let me turn this over to you, and you've got the ability to run that, and feel free to use the pointer on the mouse as well.
Yeah. No. So again, thanks everyone for being here. So I'm going to focus this presentation on acute myeloid leukemia with myelodysplasia-related changes, and I'm going to term this as AML-MRC for the remaining talk. This is really an evolving diagnostic and therapeutic paradigm, high unmet need in AML. But before we kind of focus on that, I'm going to go over some of the new classification of AML that's really pertinent in 2022 and beyond. So here are my disclosures. So again, just to reiterate some of the objectives today, number one, really to describe the diagnostic workup and criteria of AML. And we're going to really hone this in on the current classification system of AML in 2022 and beyond. I'm going to give an overview of the different subclassifications of AML that exist concurrently with the WHO, the World Health Organization, as well as this new classification system known as the International Consensus Classification, or the ICC. And finally, we're going to focus on AML-MRC, talking about the prognosis, treatment options, and some of the emerging therapies in this unique subgroup of AML. So we're going to start with a case. This is a 66-year-old male, past medical history significant for hypertension, well-controlled diabetes. He presents to his primary care physician after gradual worsening of fatigue, lethargy, anorexia, and weight loss over the last 1 to 2 months. Very, consistent with a presentation of MDS or acute myeloid leukemia. The astute primary care physician draws labs and notices a white blood cell count of 2.2. Lower limit of normal is about 4 to 4.5, so a low white blood cell count. The patient's anemic and thrombocytopenic with a hemoglobin of 7.8, platelet count of 31 or 31,000, and the absolute neutrophil count is low at 0.6, so the patient is pancytopenic. A peripheral blood smear is performed, and the primary care physician notices dysplastic granulocytes and circulating immature cells. The patient's eventually referred to a hematology oncologist where a bone marrow biopsy is performed, which reveals a hypercellular bone marrow with 28% myeloblasts, and the myeloblasts are determined by a flow cytometry immunophenotype consistent with a myeloid phenotype as shown here. So the patient has acute myeloid leukemia. Despite increasing symptoms over the past 1 to 2 months, the patient does have a good performance status. Again, he's 66, no evidence of leukemia-related complications or tumor lysis syndrome. So the question is, what is the best next step in the management of this patient? A, initiate induction chemotherapy with 7+3. B, administering low-intensity treatment with a regimen known as azacitidine and venetoclax that's typically given on the outpatient side to newly diagnosed older unfit AML patients. C, CPX-351 induction therapy, or D, provide transfusion support and supportive care while awaiting further diagnostic information. So I'll give folks maybe 30 seconds to provide their answer choice here. So we got a wide range, but it looks like 7 and 3 and provide transfusion support is dominating. Still looking like A and D are the winners. Yeah, so 40 to 45% choosing 7 and 3 induction chemotherapy, in that range also for D, provide transfusion support. There's 0 for CPX-351 and B, azacitidine and venetoclax, a few answer choices. So I'm not going to tell folks the answer choice that I would provide here, but hopefully in the next few slides we'll uncover what I think is the best answer choice here. Okay. All right. So just to give a very brief overview of acute myeloid leukemia so that we're all on the same playing field here, AML is a clonal proliferation of myeloid precursors. These are the myeloblasts. Myeloblasts are normally produced in the bone marrow. These are the most immature producing white blood cells that eventually mature and differentiate to become normal basophils, monocytes, neutrophils, eosinophils. In AML, these myeloblasts are clonal and stuck in this myeloblast phase. They have a reduced capacity for differentiation and a reduced capacity for cell death, leading to uncontrolled proliferation and a bone marrow that is filled with myeloblasts and inability to produce normal maturing white blood cells and hematopoiesis. Now, how we diagnose AML has really evolved actually just in this past year. We are now increasingly incorporating genomic abnormalities into the definition of AML, whereas traditionally, pathologically, AML was diagnosed by seeing 20% or more myeloblasts in the peripheral blood or bone marrow. Myeloblasts were basically determined by the immunophenotype of the clonal circulating immature blasts. This is done by flow cytometry, either from the peripheral blood or bone marrow, and again, really needing a 20% threshold in order to diagnose this disease pathologically. However, we've really recognized, really for decades, I would say, that there's a real bit of subjectivity in the blast percentage. And biologically, it doesn't make sense to discriminate the disease that is any different between, let's say, someone with 19% blast versus a patient with 21% blast. So there are two new classification systems that were published just this past year. One is known as the World Health Organization, which has really been the foundation of our myeloid classifications for decades, and a newer classification system known as the ICC. And the ICC classification now recognizes a new distinct entity known as MDS/AML, which is any patient with 10 to 19% blast. So this transition period between what was previously determined to be MDS and AML being 20% or more blast. So we're really blurring the lines between the absolute blast percentage for diagnosing this disease. And as I mentioned, we're really now incorporating genomic abnormalities that are sufficient actually to make a diagnosis of AML. But there are some subtle differences between the WHO and the new ICC classification. But I highlighted here some of the new genomic abnormalities that are sufficient to be classified as AML, irrespective of the blast percentage by the WHO. Any patient with any of these genomic abnormalities that are shown in this table, irrespective of the blast percentage, is now classified as being AML. The two exceptions are those with either a BCR-ABL fusion or a CEBP alpha mutation. Those patients actually still need to have 10% or more blasts to be diagnosed as AML, whereas everything else on this table here is actually sufficient to be classified as AML irrespective of the blast percentage. The ICC criteria, which is a sort of companion classification criteria to the WHO, also recognizes really the same genomic abnormalities as being sufficient to classify this disease as AML, but requires 10% or more blasts as opposed to the WHO, which does not have an absolute blast percentage threshold to now be classified as AML. So hopefully I didn't confuse you. There are two classification systems, but what we're now doing is being able to come up with a hierarchical classification system of AML where we're defining this entity genomically, which is really where the field and the advances have been in this disease over the past few years. The highest diagnostic classification in this hierarchy is AML with defined genomic abnormalities, and those are the abnormalities that I showed in the previous slide in the tables. But the second highest classification subgroup of AML in this hierarchy is now having a TP53 mutation, which has not been part of our classification system of myeloid diseases up until this point. And this is important because TP53 mutations are relatively common, seen in about 10% of MDS and AML patients. TP53 mutations are associated with complex cytogenetics or complex karyotypes, and they have been associated with worse outcomes, both in MDS and AML. So we now have a distinct genomic entity of AML that is classified with this TP53 mutation. But it turns out that nothing is as simple as it seems, and not all TP53 mutations are created equal. So there are probably two distinct subtypes of TP53 mutated AML, one being a biallelic or multi-hit TP53 abnormality. And these are patients with either two or more TP53 mutations or a TP53 mutation with a loss of chromosome 17p, that's where the TP53 gene resides, or patients with a very high variant allele fraction, above 50% of TP53 mutation. If they meet any of those criteria, those patients not only have a TP53 mutation, but they have biallelic or multi-hit TP53 mutations. Does it matter? Well, it turns out outcomes are worse in MDS with multi-hit or biallelic TP53 compared with just a single TP53 mutation. And now that we're really blurring the lines of this blast percentage, it probably doesn't matter whether a patient has 10% blasts with TP53 mutation or 30% blasts with TP53 mutation, there is a harmonization of this subclassification with MDS and AML having a TP53 mutation. And that's because outcomes are dismal in both subgroups. This is an analysis that was done showing TP53 mutations either monoallelic or biallelic in either MDS or AML. And you can see here really equivalently poor outcomes in both MDS and AML with a TP53 mutation. So this is a very high unmet need. Outcomes are significantly worse in both MDS and AML patients with TP53 mutations. They have poor outcomes with conventional chemotherapy, intensive chemotherapy, as well as low-intensity therapy. Azacitidine and venetoclax is a treatment that I highlighted in the last session that I was here just a few years ago, and has really been the most transformative advancement in AML in the last several years. This is a regimen that's highly effective in older adults who are unfit for intensive chemotherapy with newly diagnosed AML. But TP53 mutations do not seem to be sensitive to the azacitidine and venetoclax regimen. And that's highlighted by data that was recently published by Dan Pollier and colleagues showing that there is no improvement in outcomes, in fact, to the addition of venetoclax to azacitidine compared with azacitidine alone in TP53 mutated AML. So although we have new treatment advances for AML, this is a subgroup that unfortunately has not seen significant impact with our treatment advances. Clinical trials are really imperative for this subgroup, and we have a very innovative and promising clinical trial here at University of North Carolina studying a novel agent in combination with azacitidine known as magrolimab for these patients with TP53 mutated AML. So hopefully we will begin to see an impact in this subgroup of AML. So now I talked a little bit about the risk classification of AML, but the way that we stage AML has been through a risk stratification score. So we don't stage this disease like other cancers where we have stage 1, 2, 3, 4. Our staging system is based on really two distinct features. One, the cytogenetics or the karyotype of the leukemia, and secondly, the mutations that are present by next generation sequencing. And patients can then be classified or risk stratified into one of three risk groups: favorable, intermediate, or adverse risk. The most widely used risk scoring system is through the European Leukemia Net classification, that's abbreviated as ELN. And in 2022, just this past year, we have an update, a revised ELN criteria for risk stratification of AML. And I was just going to highlight a few of the changes from this risk stratification score that was updated from the previous 2017 version. The first update is that favorable risk AML no longer requires a stipulation of the FLT3 ITD allelic ratio. An NPM1 mutation is a favorable risk abnormality, and previously, if there was an NPM1 mutation along with a FLT3 ITD mutation, there needed to be a low FLT3 ITD allelic ratio in order for that to be a favorable risk abnormality. Now, in order for an NPM1 mutation to be classified as favorable risk, there cannot be a concomitant FLT3 ITD mutation, and that's independent of the allelic ratio. Secondly, there used to be a stipulation of a CEBP alpha mutation being biallelic in order to be favorable. And it turns out that there's been extensive data that suggests that it's not necessarily the biallelic nature of CEBP alpha mutations that are favorable, it's having a specific mutation in this basic leucine zipper inframe region of CEBP alpha. And those are the patients that have favorable risk AML. So that's highlighted here. There is not this basic leucine zipper inframe mutation as CEBP alpha. It is not a favorable risk abnormality. But importantly, there are several new abnormalities that are sufficient to be classified as adverse risk AML, one of which is the AML-MRC criteria, which I'll get into in the next few slides. So now kind of shifting gears a little bit to get to AML-MRC, I want to first provide some definitions to again level the playing field. Secondary AML is really an old terminology for AML, which has always been really defined by AML from previous chemotherapy or radiation therapy, and that's known as therapy-related AML, or AML from pre-existing myeloid neoplasms, MDS, CMML, MPNs, etc. That subgroup is known as secondary AML, AML from previous chemotherapy or previous malignancy. AML-MRC was a new subgroup that was defined by the World Health Organization, the WHO, which in 2016 was defined as either AML from a pre-existing MDS or CMML, so that would be a secondary AML, or AML with specific MDS-related cytogenetic abnormalities. Those are shown here in this table. These cytogenetic abnormalities are consistent with a disease biology of MDS, so we're kind of classified as this AML-MRC independent of having a previous history of MDS, or pathologically seeing what we call multilineage dysplasia, seeing dysplastic changes in 2 or more lineages in the bone marrow that is also thought to be consistent with the previous MDS. About a quarter of newly diagnosed AML patients meet this criteria, and outcomes are poor with conventional therapy. What's changed? Well, since this WHO subgroup was defined in 2016, we've really recognized that we can probably more accurately define this disease entity genomically. And a real seminal paper that was done by Coleman Lindsley and colleagues now 6-7 years ago showed that there was 8 mutations shown in blue here that were highly associated with secondary AML from previous MDS. And it turns out that patients who have one of these 8 mutations, which is called the secondary type AML on the Kaplan-Meier survival curve on the right, have very poor outcomes and have outcomes equally poor as those with TP53 mutated AML, which is, as one entity, the most adverse risk mutation that's been seen in AML, TP53 mutation. So having any of these 8 mutations consistent with the previous MDS biology has worse outcomes compared with patients who do not have any of these mutations. And furthermore, the largest genomic classification analysis that was done in AML several years ago in the New England Journal of Medicine by Papamanuel and colleagues looked at over 1,500 AML patients. And the second most common distinct genomic subgroup from this classification system of AML several years ago was this AML with mutated chromatin, RNA splicing genes, or both. This is a subgroup seen in about 18% of newly diagnosed AML patients. And this subgroup is enriched in this previous MDS disease biology, secondary AML patients, similar mutations to the previous analysis looking at associations of secondary AML. And this subgroup has worse overall outcomes. So based on all of these data, as well as other findings, there is now a new defined definition of AML-MRC by the WHO and the ICC, and this is now termed AML-MR or AML-MRC. Now what we are doing is incorporating these mutations that were defined by Coleman Lindsley and colleagues as a real defining MDS genomic population. Any patient with one of these 8 mutations, ASXL1, BCOR, EZH2, SF3B1, SRSF2, STAG2, U2AF1, or ZRSR2, is now sufficient to be classified as an AML-MRC, when previously we did not incorporate these mutations into the definition. There are some subtle differences actually between how the WHO and the ICC define this entity by mutations and by cytogenetic abnormalities, but both now incorporate these mutations into the definition. So how does this all come into play in our kind of standard clinical workup of AML? So in 2022, the gold standard of making this diagnosis is still with a bone marrow biopsy. A manual aspirate differential is really critical to underscore the blast percentage, which is still very important despite there being potentially blurred lines between a 10 and 20% blast percentage versus 20% or more, it is still very important to have that information for classification purposes. Cytogenetics in fish are absolutely critical at diagnosis in order to classify, prognosticate, and come up with treatment that's tailored to the individual. At our institution, we're really privileged to be able to get these results in 24, 48 hours, but the turnaround time is anywhere between 24 hours and a week, depending on where you practice. Thirdly, and perhaps most importantly now, is a next generation sequencing panel that is absolutely imperative to have at the diagnosis of AML. This is where we get all of the mutations and the genomic abnormalities of the individual disease. This also has a variable turnaround time. At our institution, we generally get results within a week, maybe up to 10 days, depending on where the bone marrow sample is sent for commercial assays. It can take 2 to 3 weeks to get the next generation sequencing results. Why is it important? In the last 5 years or so, we've had 9 new drugs approved for AML, and we're really moving now towards this precision medicine, personalized cancer therapy era in AML, where we now have a menu of treatment options that are really tailored to each individual genomic abnormality and each individual's unique disease subtype. We are no longer treating this disease with a one-size-fits-all treatment paradigm, and having these results is absolutely critical for us to make the best treatment decisions, both in the short term and long term. Now, a question that I get frequently from outside physicians and referral oncologists is, well, can we wait for these results that you said can take 2 to 3 weeks? The old dogma of acute myeloid leukemia is that this is an urgent disease to treat, and you can never sit on a patient with AML without treating them urgently. So the question is, can you wait 1, 2, 3 weeks to get this information? There was a international AML registry that was done by the German and Austrian group, actually looking at over 2,000 patients. And this was a big presentation at our annual American Society of Hematology conference a few years ago, where they looked at, this was a retrospective analysis, they looked at over 2,000 patients, and they subdivided patients into 4 different cohorts. Those that were treated within 5 days of their diagnosis, all the way up to those who took more than 15 days between diagnosis and treatment initiation. And you can see here that the complete remission rate was similar between all 4 groups, whether those that waited less than 5 days versus those that waited more than 15 days. There was no significant difference at all in early mortality, even in the patients that waited more than 15 days to start treatment. And overall survival, long-term survival, was very similar between all 4 cohorts here, between urgently treating or waiting more than 15 days to make a diagnosis. So I would argue not only is it safe, it's optimal to wait to get these results for the vast majority of patients. This was not a randomized prospective study. This is not something that has to be followed for every individual patient. I think there are some outliers and extreme scenarios where we do have to treat prior to getting all these results. But this should really be the default, that we wait for these results before treating an individual patient with AML. So we're now going to move to the next case here. So we're back to that case 1. 66-year-old male has newly diagnosed AML. Cytogenetics reveals a monosomy 7. Next generation sequencing mutational panel reveals an ASXL1 mutation. What is the most accurate ELN risk group and WHO classification for this patient? And I won't read the choices, but I'll let you guys read them, and you can make your selection now. I will say, as you're all answering this question, if you didn't get the previous answer up until this point, my selection would have been D. I would have waited for the results before treating the patient. I would not have given certainly would not have given 7 and 3, and I would not have administered azacitidine and venetoclax or CPX-351 without having the information that I just presented, such that the patient has now a monosomy 7 and an ASXL1 mutation. I'll give you a hint. The title of this talk is Acute Myeloid Leukemia with MDS-Related Changes.
That hint seems to be having an impact.
Yeah. All right, so D is the correct answer. So this is adverse risk AML because the patient has a monosomy 7. That's a cytogenetic abnormality that's always been adverse risk. The patient has an ASXL1 mutation, which is now an adverse risk abnormality that also is sufficient to classify a patient as AML-MRC. So D would be the correct answer choice here. Knowing that, what is the optimal frontline regimen for this patient? And this is the last question here. So now that we know this is a 66-year-old male with AML-MRC, this is adverse risk AML. A, do you administer 7+3 induction chemotherapy? B, do you administer CPX-351 induction chemotherapy? C, azacitidine and venetoclax? D, hypomethylating agents alone? Or E, a clinical trial? There may not be one only answer here. Those that that know me well and know this field know that there's probably two correct answer choices. There's probably one best answer choice and then a second best answer choice. And I would argue there's 3 incorrect answers here. So it looks like clinical trial on azacitidine and venetoclax are neck and neck. So it looks like clinical trials won with 44%. I think that is actually the best answer choice. This is a subgroup of patients, as I mentioned earlier, and I'll highlight moving forward, has poor outcomes with conventional therapy. But the standard of care for this patient population, actually probably the second best answer choice, got very few responses, and that's CPX-351. So I think that's actually a better answer choice than azacitidine and venetoclax. So CPX-351, what is CPX-351? This is a liposomal formulation of cytarabine and daunorubicin. So cytarabine and daunorubicin are old cytotoxic chemotherapy drugs that have been incorporated in a regimen known as 7+3 for decades. 7+3 was actually developed in the late 1970s. This is a liposomal formulation that was developed about 20 or so years ago that was developed with the predilection to kill leukemia cells in the bone marrow more effectively. And this liposomal ratio was created in this fixed molar ratio to have really enhanced anti-leukemic killing. So the regimen was first studied in older adults with AML and was noted to be safe and potentially effective. And there was this randomized phase 2 study that was done comparing CPX, I'll abbreviate CPX-351 as CPX, compared with 7+3, the old standard, in newly diagnosed AML patients. And this study was first done in 60 to 75-year-olds. This was not restricted for any disease subgroup or genomic abnormality. It was just 60 to 75-year-olds with newly diagnosed AML. And it turns out that the CR rates were a bit higher with CPX, maybe not significantly so, 67% versus 51%. Median survival wasn't significantly different between either arms, despite CPX having lower early mortality. But on subgroup analyses, it was interesting to note that secondary AML patients seemed to have the best response and seemed to be the group that benefited the most from CPX-351. This is subset analysis, so it wasn't the primary group studied, but you can see here median survival 12 months compared with 6 months with 7+3, and higher CR rates with CPX in secondary AML. So this led to a landmark randomized phase 3 study of CPX versus 7+3 in AML-MRC, so the exact subgroup that the prior patient had. This was done prior to the updated WHO guidelines. So in order to be eligible for this study, patients needed to have AML-MRC by the old criteria of cytogenetics only. Mutations were not sufficient to be eligible for this study. Therapy-related AML was also included, and this was done in older patients, 60 to 75 years. You had to be fit for intensive chemotherapy. And for AML terms, this is a pretty large study, 309 patients. This is a one-to-one randomization between CPX and 7 and 3. And you can see here the primary endpoint was overall survival. Median survival was 9.3 months with CPX versus 5.9 months with 7 and 3. And there really was this tail at the end of the curve here on the CPX arm with a long-term survival, potentially cure of 18% of patients treated with CPX. So this was shown to be significantly better than 7 and 3. But just like with all treatments, particularly in AML, with such a heterogeneous disease as AML, not every group of patients benefited from CPX. And it turns out there are some patients that really didn't benefit from CPX over 7 and 3. In particular, those are patients who have had prior hypomethylating agents for other myeloid diseases. In fact, MDS patients who have azacitidine or decitabine as their standard of care and then progress to AML, that's a large proportion of the AML-MRC secondary AML population. And you can see here that those patients had no benefit between CPX or 7 and 3, dismal outcomes in both subgroups. CR rates overall were significantly higher with CPX, 48% versus 33%. And further data from this study really showed that the benefit of CPX is perhaps as a bridge to an allogeneic stem cell transplant. We know that allogeneic stem cell transplants can cure AML patients who are in first remission, although the cure rate is dependent on all the other prognostic and therapeutic factors. But looking at the patients that got a remission and then went to transplant, either in the CPX or the 7 and 3 group, the red curve shows CPX. There were significantly better outcomes post-transplant in those patients treated with CPX compared with 7 and 3. In fact, seeing 3-year survival in the 56% range for those patients who were treated with CPX and then went on to an allogeneic stem cell transplant. We're getting into smaller numbers here when we do that, but really that tail at the end of the curve on the CPX treated arm are those patients who were able to go on to an allogeneic stem cell transplant. That's really where this regimen, I think, benefits patients, those that achieve a remission who are then able to go on to an allogeneic stem cell transplant. So to summarize CPX 351, this is FDA approved for AML-MRC or secondary AML or therapy-related AML, and this was FDA approved in 2017. So was one of the newer treatment regimens that really made an impact in this field. There is no age restriction by the label. This regimen is recommended for any age patients with AML-MRC, but the landmark study that led to the approval was specifically done in 60 to 75-year-olds. So we really have limited data in younger patients, despite this being an FDA-approved regimen for all ages. This is really best suited for patients who are eventually going to be an allogeneic stem cell transplant candidate. There are studies ongoing in other patient populations, younger patients, and comparing to more contemporary regimens like azacitidine and venetoclax, which again is the most transformative advancement in AML in the last few years and is a treatment specifically targeted for older folks. How do patients do in either regimen, which we don't have randomized data to compare to? With this evolving definition of AML-MRC, it's really important to know which subgroups really benefit from CPX 351. And most of the data that we have to date really show that TP53 mutated subgroup unfortunately does not benefit from CPX 351. And that is, an area that I would argue is of the highest unmet need in newly diagnosed AML. So CPX is moving the needle slightly, certainly better than the alternative of 7 and 3. Outcomes are still poor, and I think really raises the urgency of novel therapies for this subgroup. So how do we improve upon outcomes in AML-MRC? And I think the last 10 minutes or so, I'll highlight some of the work we're doing here at UNC and some of the areas of interest that I've had in improving outcomes in AML-MRC. I've been very focused and interested on agents targeting the immune system in AML. We know that the immune system is highly dysfunctional in AML patients. There are multiple immune aberrations at diagnosis and throughout disease progression that really lead to this profound immune suppression and what we call exhaustion and senescence. And from previous work that was done at Johns Hopkins, where I did my fellowship and training, and a lot of the work that I'd done with colleagues at Johns Hopkins, we looked at the peripheral blood of newly diagnosed AML patients and compared them to healthy control patients peripheral blood who do not have AML or any other underlying malignancy. And we found that at diagnosis in AML patients, there's this increased proportion of what we call senescent and exhausted T cells. T cells are immune function fighting cells that can actually recognize and fight leukemia cells, can fight cancer cells. And we found that these T cells in newly diagnosed AML patients are functionally impaired. And these are represented by the red bars here. These are TEMRA-like and TEMRA T cells, terminal effector memory cells, with CD45RA expression. Interestingly, however, when we looked at the follow-up in the peripheral blood of AML patients who responded to induction chemotherapy, there was this reversal in this dysfunctional immune profile that mimics what we see in healthy controls, whereas those who do not respond to first-line intensive chemotherapy have this persistent immune dysfunction. So we've hypothesized if we can modulate that dysfunctional immune profile after induction chemotherapy, we might be able to mitigate this dysfunctional immune profile in AML patients. Furthermore, previous data from several years ago from Johns Hopkins looked at 20 AML patients who underwent a specific type of induction chemotherapy, and these patients were serially followed in the peripheral blood with T cell subsets, and we found that at this early recovery time period after induction chemotherapy, there is this high proportion of regulatory T cells and immune suppressive cells that leads to this immune dysfunctional profile. So again, we hypothesize that if we can modulate the immune system during this early recovery time period, we might be able to make an impact in our treatment regimens. So we became focused on an agent known as pomalidomide. Pomalidomide is a second-generation immunomodulatory drug, or IMiD. Many of you are familiar with this drug because it's FDA approved for multiple myeloma. And IMiDs have a really unique mechanism of action. The IMiDs are a class of drugs from the thalidomide analogs. They interact with the E3 ubiquitin ligase complex known as cereblon. And each IMiD, thalidomide, lenalidomide, pomalidomide, interacts with cereblon in a unique way to degrade transcription factors or proteins. Pomalidomide selectively targets cereblon to degrade two transcription factors, iolose and Ikaros, which is important for immune function. And by inhibiting and degrading iolose and Ikaros, this might make an impact by leading to an immune stimulation in the T cells that we thought might be beneficial after induction chemotherapy. So we designed, this was designed in my fellowship with close collaboration at Johns Hopkins with my mentors, Judy Karp, Ivana Goyo, and was able to lead this study at University of North Carolina when I transitioned here 8.5 years ago. This was a phase 1 dose escalation study where we administered pomalidomide in dose escalation fashion after an induction time sequential therapy regimen known as ACT-DVP-16. This is for newly diagnosed AML and high-risk MDS patients. We looked at 2 different dose cohorts of pomalidomide, either for 10 or 21 consecutive days. And the schema is shown here. I'm going to try to breeze through this so that we could finish on time, but this is the consort diagram here of the study. We enrolled 43 patients who received the induction time sequential therapy followed by pomalidomide at this early lymphocyte recovery time period. Pomalidomide was started when the white blood cell count reached 0.2 above nadir, so it was a different time period for each individual patient. 43 patients received pomalidomide in 2 different dose cohorts as shown here, 10 or 21 consecutive days. So 39 out of 43 patients enrolled on this study had AML. There were 4 patients who had high-risk MDS, but those patients actually now would be MDS/AML by the ICC criteria. Although we capped the upper age limit at 65 for this study, more than a quarter of the patients actually were older, between 60 and 65. So we had a large age range on the study. About a third of patients had secondary AML, 40% had unfavorable risk cytogenetics. The median time between start of induction chemotherapy and pomalidomide administration was 21 days, because that was, again, administered at the time of this early lymphocyte recovery. We did not see any dose-limiting toxicities until we got to the highest dose level of 8 milligrams for 21 consecutive days. And at that point, there were 2 dose-limiting toxicities, one being grade 3 hepatitis and one being grade 4 respiratory failure. So the maximal tolerated dose on this study was 4 milligrams for 21 days, and that's the FDA-approved dose in multiple myeloma. Most of the toxicities that we saw were grades 1 to 2 and were really toxicities that you would expect to see with intensive chemotherapy alone. Moving on to some of the clinical activity on this study, we saw an overall complete remission rate of 77%, and more than half of these patients actually had no evidence of what we call measurable residual disease. But importantly, in subset analyses, we really saw promising clinical activity in that AML-MRC secondary AML subgroup. 85% of patients actually achieved a CR with AML-MRC. 82% achieved a CR with unfavorable risk cytogenetics. So the question is, how does this compare to what you would expect the clinical activity to be in a patient population with the same chemotherapy but without the addition of pomalidomide? Because the whole point of the study was to see if the addition of pomalidomide may improve overall outcomes. We did not use 7 and 3 in this study. This was a time sequential therapy regimen known as ACT-DVP-16. And fortunately, we had a 10-year retrospective analysis of outcomes with that ACT-DVP-16 regimen at Johns Hopkins that we compared our data to. Again, the study was ACT-DVP-16 plus pomalidomide. And when we compared our results, overall CR rates 77% versus 68%. We also excluded favorable risk cytogenetics on our study, which were included in the control group. So also hard to compare apples to apples. But when you're looking at this unfavorable risk cytogenetics subgroup, where most of those AML-MRC patients fall in, we saw an 86% CR rate compared with 52% in patients treated with the same regimen as a historical control group without the addition of pomalidomide. We saw very similar improvements in survival in this subgroup as well. So we really think that the addition of pomalidomide may be making an impact here. So we concluded that the addition of pomalidomide was safe and feasible after induction chemotherapy. We saw very promising and encouraging clinical activity, particularly in this unfavorable risk cytogenetic subgroup, AML-MRC subgroup. And I didn't show you any of the immune correlates, but we're really seeing a defined immune signature that pomalidomide is making an impact in degrading aiolos and perhaps stimulating these T cells to lead to an anti-leukemic response. So this has led to a randomized phase 2 study that is in conjunction with the NCI and Cancer Therapy Evaluation Program known as NCI 10434. This is a randomized phase 2 study of CPX-351, the standard of care, with or without the addition of pomalidomide starting on day 21 in newly diagnosed AML-MRC or therapy-related AML patients. We're including patients 18 to 75 years. There is an initial safety run-in to establish the safest and most effective dose of pomalidomide before we are randomizing patients to CPX or CPX plus pomalidomide. We are including patients with the new AML-MRC criteria. So I think some of the innovative things of this study, this is really the first study to define a population based on the new WHO and ICC criteria of AML-MRC, which it will be necessary to be eligible for this study. Primary endpoint is twofold. One, to establish the safe and effective dose with CPX, but secondly, to see if the addition of pomalidomide improves the clinical activity, specifically the CR rates, compared with CPX alone. And we plan to enroll 78 patients in a 1-to-1 randomization between CPX and alone, or CPX plus pomalidomide. I'll breeze through the translational correlates, which I would argue are really just as important to the study as the clinical study itself. We're really interested to understand how pomalidomide is making an impact in these patients, and we're looking at Aiolos expression, which is the biomarker of pomalidomide before and after patients are treated with pomalidomide. And we really want to identify a unique immune genomic signature or biomarker that defines who is going to respond to the addition of pomalidomide. We know that this is not going to be a one-size-fits-all for this treatment population. So the goal is to find the group of patients that are really benefiting from this. And I'll just mention that one of the key correlates that we're also doing is looking at the measurable residual disease impact of pomalidomide compared with those that do not receive pomalidomide. So future directions of AML-MRC, I highlighted one study that we're doing here, an area that I've been very interested in. There are other areas of ongoing investigation in this subgroup. Venetoclax is a real key player here in AML, and the addition of venetoclax to other regimens has shown promise in poor-risk AML patients, such as AML-MRC. So there are a number of other studies that are highlighted here that will hopefully improve the treatment armamentarium of this disease. So to conclude and summarize, the definition of AML has really evolved now to include genomic abnormalities into the definition. We're refining our subclassifications biologically. That is important because our treatment armamentarium in AML is expanding. This is no longer a one-size-fits-all treatment paradigm, and we're really moving more closer to this personalized cancer therapy era, where we hope to tailor our treatments based on the unique genomic profile. AML-MRC is a unique subgroup that's relatively common, seen in about 30% or more of AML patients at diagnosis, that are now being included with molecular mutations to define this entity more accurately. CPX-351 is the standard of care in this population, but outcomes are poor, and we've highlighted the need to identify investigational opportunities for these patients. Clinical trials are really imperative for all subgroups of AML, but in particular, AML-MRC. So I want to thank you all for your time. Really want to thank all of my mentors at Johns Hopkins and University of North Carolina, Judy Karp, Ivana Goyo, Leah Lusnik, and John Soroti, who have been really instrumental in some of the data that I presented. Real pleasure to be here today and happy to answer any last-minute questions. Thank you.
Great. Dr. Zeidner, thank you so much. I see we've already got one question that's come in. Let me just go ahead and put that on the board. Right. So any difference in clinical activity between men and women?
Yeah, it's a really good question. As we are developing more and more targeted therapies, it turns out that the pharmacokinetics may actually be very different between males and females. So there is AML has always been more common in males than females for unclear reasons. I don't know that there is any clear clinical overall survival differences between male and females, but there are certain treatments that seem to have a predilection in males versus females, and we're trying to uncover why that is with certain treatments that I don't have the answer to.
Gotcha. Okay, what I'll do, I'm going to go ahead and jump forward a couple of slides that I need to cover before we finish, and then we'll come back to that Q&A. So as you're watching, please go ahead, submit your questions there in Poll Everywhere, and then you have a few more minutes to share those questions with Dr. Zeidner. We'll come back to that screen and take a look. While we're waiting, I want to say thank you to the people of North Carolina for their generous support of the UCR, what we call UCRF, the University Cancer Research Fund, and the UNC Lineberger Comprehensive Cancer Center. We want to say thank you to Veni Obore, John Powell, Oliver Marth, Andrew Dodson, Nadja Brown, and Pat Muscarella for all of their hard work on each and every one of these lectures. There's a lot that goes on behind the scenes, and we appreciate it. Let's see, we do have a bunch of questions that look like they've come in, so let me go backtrack to that slide. Here we go. How do you suggest that we measure measurable residual disease?
That's maybe a topic that we can include next time for a whole hour talk, because that's a long answer. There are really two ways actually to measure measurable residual disease. One is by flow cytometry, which is probably the most widespread MRD assay. We use a central assay known as hematologics, which is a send-out test. We get the results within 48, 72 hours, and we can determine the level of leukemia detection by 0.01 to 0.02% from that flow cytometry assay. The second means of MRD would be through PCR, looking at a mutation like NPM1 mutation and finding how much of the mutation is present in the circulating cells, which you can do through the peripheral blood or bone marrow. So it's really tailored to each genomic profile, whether you would do flow and PCR or both. But I think flow has been the most widespread MRD analysis to date.
Great. And does every AML patient need a transplant?
No, not every AML patient needs a transplant. We recommend an allogeneic stem cell transplant in first remission in patients with non-favorable risk AML. So that's intermediate or adverse risk AML. Of course, there are exceptions even in patients with favorable risk AML, where there may be red flags or other abnormalities that may gear us to wanting to be more aggressive with, let's say, an allogeneic stem cell transplant. But the standard guidelines are for intermediate and adverse risk AML patients only.
Great. And we're going to take two more questions to piggyback off the men-women question. Have you seen any differences between race, ethnicity of patients and overall survival rates?
Yeah, that's a really important question. There actually is now a lot of data that's published in the underserved African American and even Latino population that there do seem to be biologic differences in the disease, how they respond to treatment and long-term survival, and there's a lot of confounding factors when looking at overall survival in different ethnicities, but there do appear to be differences in how these treatments impact different races and ethnicity. Part of that might be that the disease is different in different ethnicities. Part of that might be pharmacokinetics and different ways that folks metabolize different drugs like targeted therapies and so forth. So there's a lot of actual information that's, I think, evolving in this area that is going to be part of tailoring treatment to each individual genomic profile, perhaps to other factors like race and ethnicity that can really be tailored to improving overall outcomes.
Thank you. Sounds like we've got more lecture material.
Perhaps.
Yeah. Last question. Is there any chance to incorporate CAR T therapy for AML?
My hope is yes. Right now, no. This is another, ongoing area of active investigation. The challenge with CAR T cells in AML is finding the right target, which has been much more challenging in AML compared with other cancers like acute lymphoblastic leukemia, for instance, or lymphomas. It is hard to find a target that you can obliterate with CAR T cells that doesn't have long-lasting impact and other complications or off-target effects. So my hope is yes, but right now, it's just an area of ongoing investigation.
All right. Well, thank you for all of those great questions from our audience. That was terrific.